Well, hello again. I'm Bob Kramer. Delighted to have you back for this session on big retail health care strategies and the implications for seniors' housing and care. Now, not a day goes by, it seems, and certainly not a week goes by that we don't hear about another big retail player that's entering into the healthcare arena, either for all Americans or specifically for older adults. And differing strategies, differing opportunities they're pursuing. But the reality is, whether we're talking Amazon, Walgreens, Walmart, Kroger, Best Buy, we just see one example after another of those that see, as all of you recognize, that there are enormous needs and also enormous opportunities to meet the healthcare needs of older adults and to meet them where they live. That said, it very much relates to a core part of NIC's strategic plan, which is called Partnering for Health. And this session today is in one sense really about partnering for health. It's about what might be partners and alliances in order, if we're going to, as a sector, senior housing and care, take more responsibility, not saying, as we might have pre-COVID, oh, we don't do health care. We ship out for our health. You know, we have a great van with our name on it. It takes you to the doctor's office. And at night, we have a great relationship with the local paramedics. So we've evolved from that. And anyone thinks we're going back to those days, they're history, they're past. There's no going back. And now increasingly our residents, they've learned during COVID about on-demand services. They've learned about everything that can be brought to them. And they're expecting, in particular in private pay senior living, that if they're going to be paying, that basically their health care is going to come to them, and that it's also going to be health care that's focused on well care, not just health care that waits for a sick care opportunity to send you out because you have a need. So with all of that, this idea and the focus of this session is particularly timely for where the industry is now, where it's going, and most importantly, what the consumer expects of us when they move into our communities, and who might be partners to help us to really deliver on basically our promise in terms of our focus on the complete health and longevity of our residents. So to lead us in this panel, we couldn't have a better person to lead us and to moderate. Ann Tumlinson. Ann is the founder and CEO of ATI Advisory, a rapidly growing, now more than 40 people strong, national research and consulting firm dedicated to making healthcare work better for everyone. ATI guides public and private healthcare leaders in solving the most complex problems in healthcare through objective research, deep expertise, and bringing new ideas into action. If I had to translate that in terms of what have we seen, CMS itself really looks to the data that, and it's the analysis of their data, but that ATI puts out with regard to Medicare, MA plans, Medicaid, and so forth. And also founded and serves as the board chair of Daughterhood, a nonprofit national community that connects family caregivers with each other for support and information. And I'm proud to say she's also one of the fellows with me at Nexus Insights. So Ann, over to you.
Thank you. Thank you. Thanks for that very generous introduction, Bob, and thanks to everybody for making time this afternoon to sit with us while we explore how the very rapid and I would say disruptive growth in the retail sector entering into healthcare creates opportunities for senior living, and also I think has many lessons to teach us as a sector that has in many cases kind of a real estate footprint that depends on it depends on revenue from its occupants, if you will. Similar to senior living. So we have a lot to learn, I think, and a lot of opportunities for collaboration. Before I introduce the panel, though, I just want to set the stage for a minute, or set the table, as I like to say, of kind of the big trends that are at the bottom of, or at the kind of foundation of why we're all here talking about this today. So last year, the Medicare program crossed a really important threshold. So Medicare being the program that covers all of the older adults as for healthcare that live in your communities. It crossed a really important threshold last year, and that threshold was expenditures are now exceeding $1 trillion a year. And importantly, it crossed another threshold, which is that over half of that expenditure is now going to private health insurance companies that have a significant amount of flexibility, both in terms of how they design benefits and deliver services to this population, but also have a lot of flexibility in how they contract with the frontline providers who deliver care. What we have seen in terms of capital flowing into healthcare then is a lot of response to this, the kind of growing expenditures in Medicare, the need to get them out of a fee-for-service and silo-based system and into a value-based system. And so the emergence of a lot of new actors in the healthcare space that really very fundamentally do not fit into kind of a traditional healthcare box. And that might maybe even sound familiar to some of you. And that's another kind of a really important common point between the retail sector and senior living, which is that you're not in the traditional healthcare box. And a lot of these services and innovations and disruptions are actually, not only are they not traditional healthcare, they don't look like medical care at all. So the lines between sectors are blurring, and the types of things that we see being offered in the most kind of innovative ways, whether it's food, housing, or social support services, are increasingly becoming part of what we think of as medical care. So we're incredibly lucky to have here today with us a number of people who really represent that disruption and represent this non-traditional healthcare that is emerging as, quite frankly, a pretty big threat, I think, to traditional healthcare. And I'll just introduce them briefly, and then I'll give them a minute when I'm done with the introduction to share a little bit more about themselves. But immediately to my left, we have Dr. Marc Watkins, who is the Chief Medical Officer at Kroger. And next to him, we have Dr. Lindsay Botsford, who is the Market Medical Director for One Medical. Next to her, we have Dr. Carla Perissinotto, who is a professor of geriatrics at the University of California in San Francisco, and also a founder of palliative care and primary care companies, which I'm sure she'll talk about. And then we have Gabriel, who plays a number of different roles. He owns senior living, and also is a founder and a partner in centered care, which is seeking to try to find ways to bring healthcare into the senior living context. Okay, so I think that one of the things, if you kind of think back even maybe 4 or 5 years, if somebody says medical care to you or says healthcare to you, what you tend to picture is you may be picturing a procedure being done by a very skilled, highly trained physician in a highly capital intensive setting like an inpatient center or even an outpatient center, and being paid for by Blue Cross Blue Shield. And today, that picture is increasingly shifting into things like a setting that is the home. Providers, the person that's in your home providing the service might actually be at risk for both quality and actuarial expenditures. The other things that provider might be delivering to besides healthcare might include food or some type of transportation service. And that provider could be an advanced practice nurse or a nurse practitioner or a community health worker or a social worker. And oftentimes they're touching base with the people that they're seeing in between visits through a much more digital, free-flowing kind of while they might be somewhat clinic-based, there's going to be a non-traditional digital, what we call infrastructure to that setting. So who's paying, what they're paying for, how they're paying for it, and kind of where it's delivered are all changing and shifting. And nobody, I think, kind of represents this shift more dramatically than the retail sector. And this is just a few of the events that we've seen happening over the past year. And I'm sure many of you have, have recognized many of these events, and there are many more. But we've just seen kind of almost like a rush among retail players to buy healthcare assets or develop healthcare, whether it's partnering with insurers, becoming an insurer, developing primary care, bringing even post-acute care, home-based care delivery, digital health. Every single one of those things is essentially being occupied, space that's being occupied now by many of the top players in the retail sector. The senior living sector kind of, not on the other hand, but in addition, is slowly coming up a learning curve with respect to where it fits in this healthcare space. So we've got the kind of all along the what I call risk-reward continuum. We certainly are seeing a lot of senior living operators now beginning to form more deliberate partnerships with healthcare providers in their communities to deliver services in a more integrated way, kind of moving up that risk-reward continuum, generating revenue for services, and then even going so far as to invest in lines of business such as Medicare Advantage plans or even senior living. One of the organizations that I, kind of innovators that I love to feature is my friend Lori Schultz's company, Viva, or I should say her company's Avenue Development, and one of her newest developments is Viva Benet, which is going to open this fall in St. Louis, and already has people signed up, and many of whom have said that one of the main reasons they're signing up is because of the integrated primary care and wellness focus of this community. So really excited about that and excited to see what happens there. And maybe even I'll just end this sort of introductory remarks by saying, who knows what the future might hold? Many of us get pretty creative in thinking about what it could look like to have a middle market seniors housing and Medicare Advantage product where we really tap kind of both of those revenue streams, if you will, to create a very integrated health and wellness and long-term care product that takes advantage of efficiencies across both of those platforms. I think that's in the future. We have a little ways to go, but I just wanted to share that vision with you all. And now I'm going to go ahead and stop talking and open it up for our panel to make a few remarks. And I think I'll just start by, there we go. I'll start by, I'm actually going to start by asking Lindsay, if you don't mind, to talk a little bit. So you, I remember when One Medical came to my community, and I got this letter in the mail, and I was like, what is this? Like, this looks convenient, and it looks like very consumer friendly. Many of my friends immediately signed up and took advantage of it and were huge fans of it. And we've watched it evolve from when it started in 2007 as just like one clinic into a really big national player, and one that has incorporated into it now geriatric capabilities that are brought to it through its acquisition of Iora Health, which you were part of. And now it's part of the Amazon world. So I would just love to hear from you as a starting point about how, what is that like, being part of a startup, an innovative healthcare delivery provider organization, and being integrated into an organization like Amazon, which is obviously also very consumer oriented and much more digital in nature.
Yeah, exactly. Well, good afternoon, everyone. I'm Lindsay Botsford. I'm a family doc by training in Houston. And like Ann was saying, I had spent my first 10 years in academic settings, large healthcare systems, and then joined Iora Health as we were opening clinics in Texas. So with Iora, we were caring for older adults on Medicare, but with the idea that we were going to do it differently, kind of blow it up in terms of the traditional healthcare model, take risk and focus on health and not just delivering healthcare, to really think about how, if we are responsible for more than just a 15-minute office visit, how can you really think how you deliver a better experience for seniors. And so it's with that grounding that we joined forces with One Medical in 2021, and then a year ago, just a few weeks ago, joined forces with Amazon. As you think about maybe the larger organization now, we have about 250 offices in 24 markets. We have the former One Medical practices that continue to do the great care that they do. And we've added to that our legacy Iora offices that are now operating as One Medical Seniors. I think philosophically, Iora is very similar to One Medical as well, in that we are really driven with thinking about how we can be different than traditional healthcare, thinking there has to be a better way to do it. The goal is, better health, but better care and better value. I think part of our premise is we're not delivering very well on the value proposition in healthcare right now, and we think there's a way to do it better. So to your question, I think you're right. Amazon is very customer obsessed, which really fits, I think, with One Medical, in that we've been member experience obsessed is how we think about it on our side of the thing. We now fit within the larger Amazon Health Services basket of options for patients. When you think about the larger goal of Amazon Health Services, it's the idea that we want to make it dramatically easier for customers to find, choose, afford, and engage with the services, products, and professionals that are going to help improve health. So there's a lot there, but that's more than just we want to make a better doctor visit. It's we want to do a better job at all the things associated with healthcare. And so to answer your question, we're just scratching the surface, but I think excited because there's a big cultural fit, this commitment to focus on access for patients, focus on member experience, and to some extent the healthcare provider experience too, which is maybe secondary here, but there's a lot in healthcare that just isn't working super well, and excited to see how that frame shift of becoming really customer, patient obsessed as opposed to giant healthcare system obsessed is what gets me interested. So yeah, we'll see.
It's another nice touch point too with senior living, because a senior living kind of is grounded in the hospitality model and the model around the experience of the resident, kind of first and foremost. So they're coming almost kind of with that thing that traditional healthcare is really seeking to try to evolve into. And so I think, while we talk a little bit about what the purpose of this panel is to talk about what some of the lessons are in your experiences for senior living, I think there are lessons that can definitely go both ways. And this is maybe a good point to kind of ask Marc to talk a little bit about Kroger Health. And it is just another personal note is that my grandfather worked for Kroger Health in the 1930s as his first job during the Great Depression, so I have this kind of just fond memory in my heart of hearing those stories when I was growing up, and it's fun to see all of the things that you all are doing in healthcare as primarily as a kind of a grocery store, and one with such a long history in this country. And you've just announced that you're opening primary care clinics. Is that a good way of describing it? Better Health Group, which is essentially value-based primary care to people enrolled in Medicare. And I'm just wondering if you could talk a little bit about that, and maybe especially what motivates a grocery store chain fundamentally to be part of the healthcare ecosystem, and specifically primary care.
Well, yeah, Mark Watkins, Chief Medical Officer of Kroger and Kroger Health. And so thank you, Ann, for that question. And Bob, thank you to your team from NIC for having us. And let me just preface your question in context. And many of you may be wondering, what's a 143-year-old plus grocer doing on stage talking about healthcare, right? And let me sort of just unpackage a little bit about Kroger. As I mentioned, we operate traditional grocery stores in more than 35 states, including the District of Columbia, where you live. And so we've been doing that, as I mentioned, for many years. But more than 45 years ago, and it's probably closer to 50 years ago, we did something very, very simple. It was, we asked the consumer what they wanted from us. Hence was born, they wanted more convenience, and we got into the pharmacy business. So you think about that pivot in grocery stores almost a half a century ago, where you didn't have that level of convenience inside the grocery store. That happened during that time. And so many retailers followed. That was our first salvo. And in 2005, we actually did the same thing, and we asked our consumers what they wanted, right? So in 2005, they were looking for convenience, transparency, and also affordability in healthcare. Lindsay mentioned the same things in 2024, that still resonates with consumers. And really that began our evolution into the retail health clinics, a full acquisition of the little clinic in 2010 and so forth, and then grown that business now to a little bit more than 225 clinics. Let me just paint the picture of this intersection of food and health, and I'll be very brief. As a 143-year-old grocer, and answering why consumers are asking for these things, they just weren't there. You can rewind the clock. 20, 22 years ago, 80% of physician offices had no extended hours. They had no weekend hours. They had no holiday hours. You called them after 5, you went to the ER or maybe in urgent care, right? So you look at 2024 right now, less than 10% of primary care offices will not have extended hours or some ability to meet patient demand after hours. And that was really the evolution of what's happening generally throughout the ecosystem, not only in retail health, but in other sectors and other verticals of healthcare. What are we doing at Kroger and Kroger Health specifically? And you probably are asking yourself, what is Kroger Health? Doc, and why do they have a doctor there? So I'm trained in occupational medicine, preventive medicine, and public health. We operate a little bit more than 2,500 points of care around the country, 2,200 pharmacies. As I mentioned, the clinic business, we operate a pharmacy benefit manager, a PBM, in 17 states. We also operate actually that's more like 30 states. We operate a specialty pharmacy in 17 states, including the Puerto Rico, as well as a home infusion service line and a dietitian nutrition service line. That umbrella makes up about 24,000 associates that support that line of business, with a little bit more than 320 million transactions alone in 2013, representing close to what amounts to about 10% of sale revenue at $148 billion for the Kroger company in 2023. So just an immense business. And then I support our Total Rewards group on the HR side with our benefits for our teams. But let me, but before I close, just mention a point that is incredible and why this journey is so important to us is that healthy communities are good for business, but more importantly, we want to help people live healthier lives. And helping people live healthier lives really creates the foundation of who we are as a company, because we want to feed the human spirit first. We want to do that from food and from uplift around inspiration around food as a 143-year-old grocer. But we know, Lindsay mentioned it in terms of some of the chronic diseases that we're facing. And many of you as operators in the space understand that you're getting some of these residents at their most frailest, right? And so there's been a long track record of them dwindling over time before you even get them. So we're on this journey around improving the lives of the communities that we serve by not only food, but making it seamless for them to interact with us, whether it's on a digital platform for their healthcare, at their pharmacy, and then finally that we now have the ability to touch 98% of American households through things like pickup and delivery. So we're able to bring food to most places in America today. So I'm pleased to be part of this conversation and looking to dig in more. Ann, thank you.
Yeah, thank you. And I'm just want to flag for a moment. I mean, you're talking about healthy communities. You're talking about the important role that the food plays in nourishing not just our bodies but our souls. And I think about how the senior living providers, the communities that our older adults, my mother, among other people, live in, are really all about that social connection, that sense of community, the sense of enriched living, both enriched in a social and spiritual way, but also in a nutrition, in a matter of nutrition. And I was thinking, as I was thinking about this conversation that we're going to have, I thought about, and I'm going to kick this actually to Chip next, and then come back to you last. But is that it almost feels to me sometimes like senior living is disrupting healthcare without knowing it. It's like we're massively innovating. We've got, as we were discussing earlier, we have, regulatory requirements to do things like medication therapy management, chronic care management, assessing people for need, dealing with, post-hospital emergent situations, all of these kinds of things that we talk about in value-based care all the time. But there's not necessarily, we're not necessarily connecting the dots all the time to exactly what it is we're doing, and doing it in a much more sort of deliberate way. But I do think that's changing, and I think that's kind of where I was hoping you might start in this conversation, was like, what do you see changing? Is it changing fast enough? And where do you see the big opportunities as you look at the sector? What do you wish people would do more of?
I think be a little reflective first where senior housing has come from. We used to be skilled nursing, and then Bill Colson started building congregate care all over the country, which was really a wonderful setting and people's socialization and activities. And then assisted living started with Karen Brown Wilson, and that was a whole new thing because it wasn't a nursing home. And I come from Oregon, which has got a great Medicaid waiver program, so we were able to create a cross-section. And Generations, the business I've been a part of for 34 years, has been innovative. We did some of the first assisted living facilities, built 13 of them in Oregon, and try to most importantly listen to your residents and the customer that's out there. And we've evolved. And I always laugh about where I love visiting with our residents in one of their both formal surveys and also informally. And the number one complaint my residents always gave me is they like the socialization, they like the activities, they just don't like all the old people that are here.
Yeah, right.
And they keep saying that. You got to listen to the customer, and that's what this is about, is listening to customers. So Generations developed a number of communities that were outward focusing, that our community spaces, whether it's the theaters, the local schools would use it, the restaurants open to the public, we put credit unions in, all these different things to get the outside public there. We sponsor things for the neighborhood to come in. We put daycare, which just wasn't for our employees, but for the hospital that was next door, to try to create what our residents wanted. And as two things have been inspirational, I think, to Generations, and what we're trying to do with my new businesses with Artie Whitman is, where is this going? And one of my great book, Atul Gawande, Being Mortal, if most people have heard of it, but he talks about his father's experience in dying. And he's an Ivy League trained physician. His father was a physician, and we do a terrible job. And my goal as an operator is that when someone moves in, which is not an easy decision, they don't want to do it. No one says, I want to move into a retirement home or assisted living, but I hope it's their last home. And I hope we get to create an experience where they get to write a lot of chapters in their life while they're living with us and make their life full and wonderful. And so when they pass away, that their kids are thankful, that my employees are sad because they've learned to love them like they're their own parents, and to create that culture. And if we do that, we're successful. In this process, though, is my residents use a lot of healthcare. And we could, we pass meds, we coordinate care, we manage chronic diseases. And Senior Living Transformation Company is trying to figure out what this is. And you mentioned centered care too, which I've also partnered with Artie Whitman. And we, anecdotally, and the last panel talked about a lot, Bob and the group, is that we know we change people's lives, that they're better if we do it well. We can't prove it. And we are in a society that does that. And you talk to health plans, especially now, there's statistics, $1 trillion last year, over 50% of some at-risk plan. And you know what every one of those at-risk plans want, and they spend a lot of money, they want eyes on their members every day. They've got call banks calling people to make sure they take their meds, coordinating transportation to their therapy. We do that for them, yet we haven't participated in that at all. If they were in their own home, their health plan or Medicare would be paying for all those services that we do, and we're not getting credit for that. I don't even get a Christmas card from the health plans for all the money I'm saving them, but we should, or at least a fruitcake or something. And so what we're trying to figure out is we are part of this system. And it's not just the residents who live, I think, in the communities that we're doing, but also those members that live surrounding our communities. How do we help coordinate the care for them? And some of the bigger campuses that we have clinics in them. We partner with outside groups to come in to help manage that care. And our goal is not to be the everything. There's some companies that have got their own pharmacies, they've got their own therapy companies, and the skilled nursing groups have done better at that than assisted living, but we're all coming into it. How do we partner with those people? So Centered Care, we hired our CEO, Joelle Post. She came from the managed care. The last 2 jobs were doing technology for managed care companies, Cambia in the Pacific Northwest, which is the Blues, and then group out of Ventura, California, it's publicly traded, white label MA plans, Alignment Healthcare. And so she comes at from the payer perspective, and how does Medicare define quality? So the things that we're trying to do as we track is that becomes really valuable when they're trying to get reimbursement from Medicare. So how do we measure in the community we bought in Brentwood, Tennessee, how are we measuring quality as Medicare would define it? Not as Argentum would define it or any other of our trade groups, coming from a payer perspective. And then trying to do that and having the data so we can partner with them. I always laugh right now, we're not cutting edge yet, we're still bleeding edge, but we're losing less every month, so we're going in the right direction. But we're gonna figure this out. Demographically, we have to figure out where we're going. We can't afford it as a nation to do it the same way, and it's partnering with people to do other things better than we do, and listening to our customer. How do we make their lives better and write beautiful chapters to their lives for them and their family?
Yeah, yeah. And it does make literally the biggest difference, and not just for the resident, but for their families as well. And we're really fortunate because we have both with Lindsay and Carla are, I think, actively caring in the moment for patients who live in senior living. And so a firsthand experience of what goes well and what doesn't go well, what's hard and what's not. And that's the least of what they do, but, or not the least, but it's among many things that you do. And Carla, you are a professor of geriatrics and are also, I think, the founder of a home-based primary care company and palliative care company. And I think, you and I probably share some of the, I don't want to call it skepticism, but a little bit of the concern around, how do we all of the things that we're talking about, the consumer orientation, the convenience, all of those things are really important, but we do need continuity of care and a longitudinal view of the patient. And sometimes in certain retail settings, that's going to be a hard thing to do because it might be a one and done, a kind of a visit, an emergent visit that's not necessarily connected to preventative care, other things like that. And I'd just love to hear you talk a little bit about what should we be concerned about, and maybe how can we address some of those concerns?
So I hope everyone's okay with skipping happy hour because I have a lot to say about this. Just kidding. It's an exciting time in healthcare, an exciting time in senior communities. But what drew me to geriatrics and to become a specialist and go on for specialty training is recognizing that our healthcare system doesn't work for older adults. We continue to try to apply models to people who are aging and expect it to work, and we have evidence that it doesn't work. We see this with our expenditures, so we need to do things differently. And part of that is keeping the person at the center and recognizing, just as the Hartford Foundation found, is that asking about what matters is actually really important. One of the most gratifying moments for me as a geriatrician is when I have someone who's in their 90s who has clearly had a lot of experience interacting with the healthcare system that says, no one has ever asked me that question. No one has ever asked me, do you need help getting to the bathroom? No one has ever asked me, what is enjoyable to you? No one has ever asked me if I'm lonely. And that is really at the core of what we do as geriatricians, is seeing the entire person. That means talking about health and longevity when it goes well. And it also means having those difficult conversations when I have to say to someone, you know, actually your breast cancer screening, even though it is a Medicare quality measure, isn't really applicable to you anymore because that's not your life trajectory right now. And those are the types of models that, unless we really engage experts in aging into new models, whether it's retail health or others, we will continue to fail. And so it surprises me as we have national dialogues around aging that often the people missing from these discussions are geriatricians or gerontologists or other people with a passion for aging like Lindsay has. And if we don't do that, and if we don't include older adults at the table, we will continue to fail. And so it is an opportunity for us to really, I think as you're saying, talk to the resident, what's important. If you look at how we use smartphones, they were not designed for older adults in their current fashion. Maybe as we get older, we'll be more used to it. But little things such as the moisture on our fingers and how that impacts our touch screen, those are things that we know we need to recognize as different in aging. And so that's really the disruption, is to own what aging is and to lean into it rather than away from it. I like to say that I'm ageist, but I'm ageist because I don't like seeing younger people. I only like seeing the older people. But there's a great opportunity. But that's what scares me, is really shifting the location of service. Even though I do home-based care, that's not the full picture. And if we really don't look at aging as a whole thing, both in the positive, negative aspects of it, we will continue to fail.
Yeah, I love that. And I think one of the things I see in our daughterhood community a lot with family caregivers is a remarkable reluctance just to face the realities of aging and what's going on with their parents. And they'll say things to me like, you know, the content on your site is depressing, or, you know, I'm not quite ready to confront that yet. And I know the senior living operators deal with this all the time, and the expectations that a 90-year-old with Parkinson's is never going to fall, for example, when we know that that's, no matter how much, physical and occupational therapy we provide and great therapeutics, we're still going to be dealing with, a disease of decline to a certain extent. And, I think as much as we talk about the importance and we recognize the importance of primary care in the management of these kinds of chronic diseases, the management of chronic conditions is also about major lifestyle factors. And Mark, I've heard you talk about this so much and so passionately that, Kroger Health has food as medicine as a really major strategic focus area. And I think there's such an important connection point into senior living, because a big part of what senior living does is provide food and food service. And just love to hear you talk a little bit about, the role of lifestyle food in the management of chronic conditions, above and beyond sort of how we think about the caring of these patients in purely a medical or clinical setting.
Yeah, well, thank you. And, at Kroger Health, we really believe that food as medicine is a dedicated, educated, and personalized approach to eating and enjoying food so that you can live healthier lives, but also to prevent disease before it starts. So we believe that it's a preventive tool. You are what you eat. We've heard that before. But let me just maybe back up and put a little context to it, because has anybody recently traveled, and I'm sure I can, maybe I traveled abroad last year, and I went to Greece. And the very first thing my friends asked me when I got back, they didn't ask me what, an ancient civilization like Greece, what did I see, what did I do? They asked me what I ate.
Right.
They were more concerned about the food that I ate and how was the food. So food is part of our life.
Yeah.
Right? Food is, we cry with food, we celebrate with food, right? You have an anniversary, you have a celebration, it's always around food. And it's very, very personal. And it has significant cultural ramifications for folks. And so this dedicated, educated approach that we're on is to really make sure that we personalize the offerings with our teams of dietitians to really make sure that we're curating the right sets of food. And to that point, when we are creating things like our medically tailored meals, and which we really believe can be the next opportunity to course correct some of these issues with chronic disease, because there's some studies by our friends at Tufts University up in Boston that suggests that if you're deploying about 10 meals, 10 meals over, actually it's about 10 meals a week over an 8-month period, so 5 lunches, 5 dinners, could you potentially impact about 1.6 million hospitalizations in a year? And then you look at the total cost of care with that being about, close to $14 billion. So there's enough opportunity there in terms of deploying a solution for a defined set of time that could potentially impact health in individuals. The fact that these meals are then curated by the dietitians with a lot of emphasis on things like cultural sensitivity, taste, preference, really makes it enjoyable, so it doesn't go to waste. I believe I shared a story with you last night over dinner. My mom, before she passed, she had her older cousin call her up and say, "Hey, Liz, I got all these, I have all these Meals on Wheels. Do you want them?" And she's like, "Yeah." So bring them over. And so she brings them over, and I get a call from my mom the next day, and she says, "I wish my cousin never gave me those. They all taste like sawdust. They're horrible," right? And so the thing about taste and how it didn't appeal to her, it didn't appeal to my cousin either, and that's why she gave it to my mom, right? So that's probably the reason. But again, really looking at this as an opportunity to course correct around chronic disease. I talked about how we're in this incredible inflection point in the history of disease in our country, with kind of costs being tied to these runaway chronic diseases that we're all faced with. And you can kind of lump them into the big three: obesity, cardiovascular disease, diabetes. I will give you one more that this audience and my clinicians here know probably what I'm going to say, that poor nutrition and obesity is now linked to 13 different cancers that are clearly linked, with obesity being the number one risk, or number one modifiable risk factor for about 13 different cancer types. And so that is, again, driving some of the issues that we see on our claims data at Kroger. We see it in the populations that we serve, and we believe that the food and food as medicine can help course correct. And before I finish, I think it's also important that when my colleague here is talking about the fact that there's some tremendous failures in the traditional healthcare model, we recognize that's a recognition that many of us have in the space, that it's way too complicated. I still can't read an EOB. I'm not sure how many of you can read an EOB, right? I don't know what an explanation of benefits really means. But imagine navigating a system that's unfamiliar to you, right? I heard you just talk about using a touch screen and it's not working for you, right? How frustrating that may be. You may be not asking the right questions. So we believe that healthcare should be personalized, not generalized. We also believe that healthcare delivery should be value-based, not volume-based. So we've been on this mission for a long time to, at some point, I think you mentioned about senior-focused care, things that we're doing in primary care and primary care light, really looking at transforming our models to make sure that we are meeting the value continuum curve, that we are not only affordable, but it's the right care at the right time for the right folks. So I'm really glad you asked me that question.
Me too, because it's I'm now going to go back to Chip and ask you, so we're hearing from Kroger Health.
Right.
talking about value-based care. So for Kroger, just to make a very big point about this, like Kroger grocery stores, a retail space with a real estate base to it, where people come in to get one thing and now they can get food as medicine, Kroger Health, primary care. What are the lessons for the senior living industry if Kroger can become Kroger Health?
Yeah.
You know where I'm going
Wake
with
up
this.
senior housing. We've got Kroger Foods and Amazon sitting up on the same stage with me. They know the demographics. They're capitalist. They've got shareholders and return on their investment.
Right.
We need to figure out how to work together. We know this industry, sometimes to our detriment, because you do the same things over and over again, and that is the definition of insanity. I think things are going to change. And so how do we understand our business? We know both these companies have invested a lot more than data than we ever have. I mean, Amazon sold books.
Right.
And lost a lot of money in the process knowing to get where they wanted to be and understand that. Kroger Foods has been selling groceries for a long, long time, and they're evolving. And we as a senior housing industry have to change. We know how to care for people. We have eyes on members, but we need to be entrepreneurial. We need to be collaborative. And we need to know what we do and what our residents do. And I think we've got a wonderful opportunity. I personally think healthcare is so complicated, and you look at the numbers. And what happens if you moved into one of our communities and your healthcare was included, your primary care was there, your lab work was done there, your medications were managed there, your adult daughter didn't have to drive you anywhere, we can treat chronic diseases. That's what the customer wants. And if you have, I've got a 115-unit community in Brentwood, Tennessee we just bought, and I've got a 460-unit with 500 residents in San Diego. If they all had the same health plan, how more cost-effective and efficient we could deliver care. And I wouldn't be surprised that 5 years ago that the health plans are one of the largest operators of senior housing. Because it won't just be for the residents who live there, but be for the residents who live in the communities that they're serving and want to collect those premiums from Medicare. And so I think if we don't see it, we're going to miss it. And I think the next 5 years is going to be some of the most entrepreneurial opportunities we're ever going to have. And I'm glad as a capitalist myself there's no more operators here right before happy hour so we can figure it out first.
Right.
Well, I think you touched on something that I wanted to ask Lindsay and Carla's perspective on, because the holy grail of population, how do I say this? The holy grail of managing risk, maybe is a good way of saying this, managing, actuarial risk in healthcare is having knowledge of emergent conditions that are going to become acute medical events far enough in advance that you can intervene before somebody hits the hospital. Yeah. But that requires a lot of knowledge about what's going on, very subtle signs and information about what's going on clinically with somebody in time to make that intervention. And I think, Lindsay, this is probably at the very heart of what you all were pioneering in IORA, like long before anybody else was, under those kinds of total cost of care risk models. And I'm just interested in, seniors housing offers an environment that has that kind of 24/7, eyes on the resident. And, do you think there's, as we have that kind of human touch in that environment, are there opportunities to kind of blend technology with that would, I guess, kind of tap that value? So it's value that we have because we have all of these people in one place, we have our eyes on them, we have them in relationship with the workers in the building, but there's probably one more step that we need to do to really unlock that value. And that's probably in the realm of technology. And I'm interested in your experience with that as somebody who has a lot of experience managing risk for complicated populations.
Yeah, I wish I could say we have it completely figured out. I don't know that we do. I think, at our mission, we are a human-centered, technology-powered company, and it's not a coincidence that the two of them are in that same sentence, because you really can't do one without the other and think you're going to succeed, especially in a value-based care space where you're trying to manage risk and deliver a better experience and better value. I think maybe I'll share a couple experiences and then a couple things that I think about. I think when we built our initial clinics geared towards older adults on Medicare and said, hey, we're going to take on risk, we're going to do this, we're going to manage care, whether they're coming in to see us or not, outside our walls, inside our walls, in their home. And what we knew is that we needed to build relationships. So I think at the core of the model was that relationships matter. And you can't go for episodic visits to, even multiple doctors within the same system. You need that continuity relationship. And what we saw over time is that when we had that relationship with a patient at 2-3 years, not only were our patients more satisfied, remember the customer experience that's important, but we saw healthcare costs go down. But it takes time. This is not something you're doing quickly. I think the other piece, though, is we built teams for that relationship. There's a primary care shortage. There's not enough of us to go around. But it's a team sport. And we often picked up on important cues, rising risk, as we sometimes call it, not from our doctors, who are good, but the time is limited in a room, even in an extended setting, but from our member support specialist sitting at the front desk that said, hey, Mrs. Smith has walked in a couple times this week without an appointment. I'm wondering if there's something going on with her memory. Or because we have community rooms where patients or non-patients could come and, actually using their input, bingo was the most popular thing. Us physicians were like, let's do a healthcare education series on this. But no, bingo and lotto is what was wanted. But they would come in to play bingo even without a visit, and we'd notice that, hey, it's taken her a little bit longer to get back to the room. Her legs look a little more swollen. And we could say, hey, you want to come back for a visit? Let's check your blood pressure. Let's check your weight. So I think it gives, when you have those relationships, whether it's with a healthcare worker or someone that just knows the patient, you pick up on things. And I think that's where we really saw the secret sauce and the difference. We think our physicians and our providers are great, but it's not just them that are making the difference. And I think that's the interesting thing when you think about, ways to impact health. How can housing impact health? Well, it's also the people in the housing facilities and in the places that could make a difference as well. So with the right paths to communicate, it can make a difference.
Right, and that's a big one.
That's the opportunity for senior housing, because we know if someone eats in the dining room for breakfast every day and they miss 2 or 3 days, why? And other than the kitchen staff doesn't get there, or their caregiver, that's the red flag in a population health management or at risk, that a change of condition and having the technology in our communities is the red flag to get their blood pressure checked and doing those types of things. And we have eyes on those people, and we know it, but more times than not, we're not doing anything with it. And I got to tour the chief medical director for Kaiser of Southern California. I had 68 of his members who lived in my community. He had no idea we were in one campus. And he told me every time you call 911, it costs Kaiser $30,000 on average.
Right.
And more times than not, they're dehydrated or something, they fall over, and we call 911 because we don't want the liability to get them off the floor.
Right.
That's a messed up system that we got to change.
And every time they go through that whole process of the ER and the inpatient stay and the SNF stay, it's taking, not only days out of the L at that moment in time, but it's shortening their lives. So there's a huge, what's nice is the incentives really are aligned in senior living. The longer somebody lives, the longer they're a resident, the better your occupancy. These things are aligned, and yet sometimes we don't really see You know, there's so many other things in the industry right now that are plaguing operators and owners that are sort of more top of mind, that this is getting a little bit more of the short end of the stick. But it's not, that's kind of what we call an actuarial death spiral. You know, it's like you can focus on, you know, that ultimately the solution to a lot of the problems that we're facing both in traditional healthcare and in these disruptive sectors is actually to move even more aggressively and faster into value-based care and to have a value-based care strategy.
Yep.
I just wanted to note that one of the areas that's really concerning is around patients with cognitive impairment, the progressive dementia.
Yes, thank you. Yes.
In terms of the risks of fragmented care, of polypharmacy, again, that's one of the main things that I get as a geriatrician is deprescribing around some of these issues. And I think, you know, some things have been mentioned importantly around signal detection. And I think that's one of the areas that if you understand cognitive impairment and understand these subtleties and understand the subtle differences, there's a huge opportunity. I do worry about so much talk around remote patient monitoring. More data isn't necessarily better care. That's been proven in data over years that we have to be very cautious with that. And it also goes against the mantra in geriatrics. In geriatrics, it's often less is more. And often, you know, what I would teach my residents is the therapeutic do nothing. Wait, just wait. Often, before we intervene. I just had this case last week with a woman who I was seeing in assisted living who was very off. And I talked to her son. I said, listen, this is what we can do. We can send her to the hospital. If I send her to the hospital, she's going to be restrained. She's going to be put on antipsychotics. It's going to take her 2 weeks at minimum to recover and delay this cancer surgery that she needs. The alternative, let me draw her labs at home. Let's get a one-on-one caregiver tonight and watch. She never went to the hospital.
Wow.
You know? Did I get anything from the health plan? No. Maybe in the future I will. But I know for this person that was the right thing. But it's really sometimes slowing down and being careful, but making sure we can detect those signals, as you're saying. And those things like having staff, either where they're living or in the physician's office, that know this patient can pick up those subtleties. That's still so critical, which is why we have to be careful when we scale that we don't lose that individual relationship that you talked about.
Yeah, but that's what has to be different. The payment model has to reward that. And so if we think about, you know, how do you support health and how do you incentivize that your outcome is health and not just delivering a service. And so that's really the difference maker, so that you can call your doctor's office or at 2 in the morning or whatever it is and ask that question, not just send 20 pages of your remote monitoring data the next day that's going to sit in someone's inbox and not be looked at. So,
and not have the automatic call 911 because you're afraid, but think about the other alternatives. I mean, we could talk at nauseum about, you know, hospital at home and all these other things, but
yeah. So this clock is telling me that we're out of time, and I think you can see that the 4 of us could talk for another hour quite easily. So I see Bob standing in the wings, getting ready to wrap up for us. So I'll invite him to come on stage.
Thank you, Ann. Please join me in thanking our panel. We had a pre-panel discussion over dinner last night that was unbelievably animated. And I think one of the things that I love about this panel is their passion for these topics, and that we must and can do better, and their excitement about that is infectious itself in a good way. And so thank you, Ann. Thank you to Diane, Ty, and Milken for the efforts to pull this panel together as part of the NIC and Milken partnership, and we are really grateful for that. So now, we're wrapping up. I'm literally standing between you and the reception and drinks, so don't want to take very long for that. I want to remind you, tomorrow morning we have one of our innovation labs, do this, not that, innovative operating models for boomers. That'll be at 9 a.m. And then at 9:30 in the main stage here, we'll have a fireside conversation between Dr. David Grabowski and Dr. Meena Sesamani, who runs the Center for Medicare and is Deputy Director at CMS. A fascinating, I think, conversation. As I've said before, This is the first time she's ever come to interact with the private pay senior housing and care sector. There's a reason she's coming, and I hope you'll be able to join us. As you leave tonight, again, here's the QR code for the session feedback. Very simple thing on the kiosk too, on both aisles. It'll only take you a couple seconds to fill it out. We need your feedback. Thank you again. Have a great evening. Enjoy the receptions and the dinners and wherever it is you're going, and we will see you tomorrow morning. Thank you very much for attending.